Hi, and welcome to Attentive Healthcare Solutions webinar, Regulatory Changes to be Aware of for 2021 and Beyond. My name is Chelsea Grover, and I'm the Marketing Communications Coordinator for Attentive. Before we dive into today's webinar, I'd like to take a moment to explain the process for the presentation. First, I'd like to mention that we will be recording this webinar and that we'll send out a copy of the slides along with the recording within the next week. Next, for those of you who aren't familiar with Attentive, I wanted to share a bit of who we are with you. We specialize specifically in next-gen healthcare, and we're passionate about providing solutions for our healthcare provider partners, which in turn help them to improve patient care, enhance the patient experience, and maintain a financially healthy practice. To sum it up, we do everything next-gen. We also have next-gen add-on productivity solutions, including ChartGuard and Refund Manager. Next, I wanted to mention an upcoming webinar that we'll be presenting on August 12th. We'll be doing, I totally forgot which one we're doing, sorry, the PM reports you never know you needed. So in that, we're going to cover PM reports that your practice can use to get a better grasp on how your PM productivity is looking, on ways that you can keep a better focus on how your practice is doing, and some reports that you didn't know existed. Well, probably didn't know existed. So join us for that. We'll send out an invitation to that a week before the webinar, so keep your eyes out for it. So back to today's webinar on regulatory changes to be aware of for 2021 and beyond. At the end of the presentation, we'll open the floor up to questions from you. We'll answer all the questions at the end, but you can type them in the questions area of the webinar control panel whenever they occur to you. And finally, for audio clarity purposes, everyone's phone will remain muted throughout the entire webinar. If you experience audio issues, please use the chat box to let us know so we can resolve them. And again, questions may be entered in the questions box. So without further delay, I'd like to introduce our presenters for today. Lindsay Lanning is Manager of Client Development, and Carly Hogan is Client Solutions Administrator at Attentive. So Lindsay, it's all yours. Feel free to get ready, or feel free to take it away when you're ready.
Perfect, sounds good. Well, thank you, Chelsea, and thank you everyone for joining us today for our webinar, Regulatory Changes to be Aware of for 2021 and Beyond. Now, I understand the amount of healthcare industry news coming out on a daily basis, especially right now, can feel pretty impossible to keep up with. How can you sort through what new regulations are meaningful for your practice, what new legislation will affect how you care for patients, or how you need to document in NextGen? All the while, treating patients or running your practice, whatever your role may be. It's impossible to do both effectively, and I get that. Believe me, this is my full-time job. Excuse me. So I don't know how you could do it with everything else you already have to manage. So today we put together an educational webinar to really break down the key points of every kind of upcoming need to know regulatory change, how it will affect your practice, and if you will need to install a patch or upgrade NextGen to remain compliant. We will be reviewing, many topics, including appropriate use criteria, 2021 E&M Coding Changes, the Cures Act, EPrescribing Updates, patient portal changes, new ONC Certification. I mean, it's endless. So obviously there's a ton of information that we try to present in a very, straightforward, cut to the chase format. So hopefully you can stay on for the full hour, as I am sure it will take the whole time, and you find it helpful versus overwhelming. Carly and I tried our best to truly, cut the fluff and get to it, so to speak. So let's do just that. So the first topic on our agenda, due to its huge impact on practices, is actually the Cures legislation. So the bipartisan 21st Century Cures Act was passed and signed into law in December of 2016, so it's been a while. This was actually a landmark bill when it was signed into law. It's an act to accelerate the discovery, development, and delivery of 21st century cures. Really, it was designed to, accelerate medical product development and kind of bring new innovations and advances to patients who need them faster and more efficiently. So you might be thinking, way to be pretty broad and vague, Lindsay, when you just said you were going to cut to the chase. Well, my apologies. This is a huge piece of legislation that impacts almost every aspect of the healthcare industry. I am talking everything from pharmaceutical and medical device companies, med schools, hospitals and doctors' offices, mental health and substance abuse treatment facilities, health information technology and software companies, even consumer and patient safety groups. And I mean, we're only honing in on two very small pieces of this legislation that impact health IT today. So those two main categories included in the final rule on health IT policies that will, and honestly already have, had an impact on each of you are the EHR certification program changes and the implementation of information blocking statute. So with the ONC EHR certification program changes, they focus on new certification criteria, aka required product functions. So the rule finalizes new and revised EHR certification criteria that EHR companies, hint, hint, Nextgen, will have to develop, test, and bring to their clients and have them live on within 24 months of official publication of the rule. And they have to do this to maintain. So that's required for any providers who might participate in MIPS, any ACOs or CPC Plus, or any kind of other quality reporting program or APMs. The application programming interface, or the API, also must meet this HL7 fast healthcare interoperability resources. It's called FHIR release 4 standard. There is a 36-month deadline for this electronic health information export requirement. And then the conditions and maintenance of certification requirements are a list of 6 new business practices or actions that EHR companies must meet to maintain certification. So what this means is there's a ton of stuff Nextgen, or if you aren't a Nextgen client, whoever your EHR vendor is, will have to add or update to their product, which means your EHR or PM system, in order to maintain this certification, which is required. So what this means in one word is upgrades. Now, I said on the first slide that these changes will and already have impacted you, and here's Exhibit A of something that has already been done by Nextgen as a result of the Cures Act. I am sure everyone on this call received an email from Nextgen with the announcement you see here around the end of June. I think I got mine on the 29th. Without reading everything, it says, basically, the regulation prohibits certified EHR vendors from enforcing certain types of contractual restrictions on communications. So this mass email Nextgen sent out addresses that, and was a result of the last bullet on the previous slide, those conditions and maintenance of certification requirements, or that list of 6 new business practices that EHR companies have to meet to maintain this certification. So under the final rule, developers have to adhere to these conditions beginning September 30th of this year, and they have until March 31st of next year to provide the required notice. So 1, now you know where this is coming from and the reasoning behind it. And 2, hopefully this makes you feel good. Nextgen is really on top of this, since providing this notice wasn't even required until March of next year, technically. The second part of this act revolves around a very prominent topic in the industry and kind of a new favorite buzzword or phrase, we'll say, information blocking. So information blocking means a practice, by a healthcare provider or a health IT developer that, except as required by law or specified by the secretary as a reasonable and necessary activity, is likely to interfere with, prevent, or substantially discourage access, exchange, or use of electronic health information. Actors do not have to comply with the information blocking provision until 6 months after publication of the final rule. And enforcement of information blocking, civil monetary penalties, that should grab everyone's attention, will not begin until established by future rulemaking by the HHS Office of Inspector General, or the OIG as we call it. As a result, actors will not be subject to penalties until that rule is final. All right, so here is kind of the 411 on this extremely popular topic. CMS is the entity that reviews activities regarding information blocking. In 2015, ONC issued this information blocking congressional report, which basically concluded in so many words, information blocking is a serious problem in healthcare, and Congress should prohibit it and provide penalties and enforcement mechanisms to deter these practices. At the same time, Congress enacted MACRA. You all know, my favorite piece of legislation that created MIPS, but it also required, for these purposes of demonstrating meaningful use of certified EHR technology, that providers have to demonstrate they have not knowingly and willfully taken action to limit or restrict the compatibility or interoperability of EHR. So to implement these information blocking prevention provisions, CMS, as part of MACRA, adopted these attestation requirements consisting of basically 3 statements about a provider's use of their EHR. So to satisfy the promoting interoperability category, under MIPS for providers and the PI program for hospitals, a provider has to actually attest yes to each of these statements. We all remember these. We have to add them to the HQM submission file before we submit or we get an error. And kind of years even back before that, when we used to report through the CMS portal, they were these annoying pop-ups that you had to click yes to even get to the next page to input your numbers. So the Cures Act basically took this to a whole new level, and it defines information blocking and creates possible penalties for these practices. So this means just like HIPAA penalties, notice it's the same office for HIPAA enforcement, the OIG, is being used, information blocking will be following the same sort of setup of audits and penalties that will impact your practice in the near future. So, we get those headlines in our email boxes of, this crazy HIPAA settlement. I wouldn't be surprised soon if we're seeing some crazy information blocking settlements. So I know we're only a couple slides in and I've dropped some, I would say, pretty good sized bombs on you all. So let me use the next few to kind of recap the important points and provide you with a true practice impact and some timelines. I promise you this first section is probably the most painful to get through. So first up is the timeline surrounding these rules. So the final CMS and ONC rules were released to the public on March 9th. However, the rules weren't officially published in the Federal Register until May 1st, setting the compliance deadlines, which if you notice in the last 2 slides mention, 2 to 6 to 24 to 36 months out from its published date. And that's May 1st, not March 9th. So on top of the whole, we released this, but it's not officially published yet nonsense, we had a global pandemic happen. Which the agencies decided to grant some leeway as a result of COVID. So CMS announced it will exercise enforcement discretion for 6 months after any of the insurer or hospital compliance dates. And ONC announced it will exercise the same enforcement discretion for 3 months after any of those certification program compliance dates. So the OIG, the big bad penalty man, also released its proposed rule on the enforcement for information blocking. And it said it won't enforce information blocking penalties until 60 days after the final rule is published. This means the deadlines don't actually change, but if you don't have what you need to implemented by the deadline, you have sort of this grace period where these agencies aren't going to be hunting you down for a few months, depending on the provision. I get that was a lot of information, so I've included the table that was released by HHS that summarizes all of these, deadlines and grace periods on this. So what this means for you from both of these rules is that by November 1st of this year, you will need to make sure you are not participating in any form of information blocking, which means you need to be responding to any data exchange requests per the CMS rule. Now, CMS, OIG, ONC, they still haven't established policies, truly are finalized those appropriate disincentives for healthcare providers to actually enforce this regulation, but it's coming. And we know they love to give a time period of, let's say, 6 years or so to go back and audit you and still penalize you. So you want to start on that November 1st and, you want some documentation in case of an audit or penalty. Second big deadline is May 1st, 2022. This is the compliance deadline plus 3-month grace period for providers to upgrade to the new Cures Act certified edition of EHR software that'll be required. So that May 1st, that's 24 months after the May 1st, 2020 publication date. And you can see this image we took directly from a Nextgen presentation. It has the ONC requirements for Nextgen at the top, and then the CMS requirements for providers along the bottom, that this Cures Act, certified software, you can see here will be actually the spring 2021 or the Phoenix release of Nextgen Enterprise EHR and PM. Now, I'm hoping I wasn't the first person to break this news of essentially a mandatory upgrade by May 2022. And you had heard this before, but just in case, here is some clarification surrounding this. It is a Nextgen Enterprise system upgrade. The deadline is 5/1/2022 with a 90-day no enforcement policy due to COVID. It will require a Nextgen portal upgrade. The MedFusion portal within the PXP platform is the go-forward portal for Nextgen Enterprise as of the spring 2021 release. Because, without getting into all the details here, the 21st Century Cures Act did also add, ONC certification requirements on the portal side. So the MedFusion portal is the native portal for that Phoenix release. To say it another way again, the spring 2021 release will not support Nextgen Legacy portal. So you will be expected to upgrade to that MedFusion portal before or during your upgrade to that spring 2021 release. All of that needs to happen sometime before spring or summer of 2022. Again, I hope I wasn't the first person you're hearing this from and the phrase "don't shoot the messenger" comes to mind, but at least I put this all at the beginning before I potentially lose you all the longer I talk. Now, as another clarification to that provider impact slide, and I don't know why I'm calling it a clarification, to be honest, it's an additional requirement. As a part of the information blocking deadline, besides just responding to those data exchange requests, CMS is also requiring providers to update their NPES profiles with their digital contact information. So the Cures Act actually required the Secretary to create this Provider Digital Contact Information Index. To meet this requirement, CMS updated the National Plan and Provider Enumeration System, that's NPES, think where your providers got their NPIs assigned, to capture this digital contact information for individuals and facilities. So all the way since June of 2018, actually, NPES has been updated to capture one or more pieces of digital contact information. This includes, and most familiar for everyone, is a provider's direct address, aka your Nextgen share email address that looks something like, I've seen firstname.lastname@direct.nextgen.com or something similar. It is not your provider's personal email address, it is their direct address. NPES has also added a public API, which can be used to obtain contact information stored in the database. So you can have access to all providers, direct addresses. Now, because many providers have not yet submitted this digital contact information, and whatever is there is most of the time out of date, CMS finalized a proposal to publicly report the names and NPIs of providers who do not have digital contact information stored in NPES beginning the second half of 2020. So that's technically now. So no penalties associated right now. They're just taking the route of trying to publicly shame providers who haven't done this yet. I'm not sure if this will work, so I would just suggest getting in there and updating this information as soon as possible. Any of you that I've ever assisted with MIPS before, and we've run into the issue where that PI measure, send CCDA, wouldn't work because the provider you wanted to send that referral out to wasn't in the Nextgen share directory. This is working to solve that issue. But it does require each of your providers to update their NPES profiles, which, depending on how large you are, may be quite an undertaking. So in summary, again, this list was taken right from one of Nextgen's own PowerPoints. Truly, we couldn't have put it any better for a breakdown of kind of the who, when, what, how for what's coming down the pipeline. And this almost serves as an agenda for our topics we're going to cover today anyway. So you can see, up top, Cure CMS information blocking provisions. We already covered that, thank goodness. You have these deadlines of November 2020 and what to do, update your NPES profile and respond to those requests. We have E&M Coding 2021 guidelines and AUC, which we'll cover both of those next. Those have a deadline of January 1st of next year, and we'll go over the actions and how to prepare for these with either, an upgrade or a patch. This NCDP, it's actually revolves around e-prescribing. We'll cover these details today again as well. That has a September 1st deadline, and then kind of what to do. And then lastly is the Cures ONC certification, which again, we have already gone over. And that deadline is at May 1st, 2022, with the 90-day non-enforcement period, and really revolves around having to upgrade your EHR, PM, and portal. We do have the same timeline and information for Nextgen Office available. No, we have not forgot about you, and no, you're not excluded from these regulations, unfortunately. My advice would be just to watch out for Nextgen Office updates and training was what seems to be the consistent messaging. And then last but not least, if the bulleted list just didn't do it for you, here is another graphic from Nextgen depicting each of those requirements and timelines with associated versions and patches for your viewing pleasure. I don't want to beat a dead horse here and talk through this. I have included this for your reference when we send out the slides, and at the end of each section today, based on topic, we will give you the Nextgen requirements as an upgrade or patch scenario. So this slide will likely become your best friend by the time we talk through each one of these, but you will be having this as a reference once we send out the slides after. All right, so on to E&M coding changes for 2021. The major changes we will see go into effect starting January 1st, 2021 are that the history and physical exam will no longer be used as determining factors for the level of E&M codes 99201 to 99215. Providers only need to document a medically appropriate history and/or examination. Medical testing, or MDM as we'll refer to it, will be one option for determining the level for E&M codes. In addition, that MDM criteria has actually been updated. Time will be the only other option for determining an E&M level for those office codes. In addition to that, the guidelines and thresholds for time have also changed. And then also 99201 will be removed from the code set completely. Again, these will only impact office and other outpatient codes for 2021, which are the E&M codes ranging 99202 to 99215. Just wanted to stress that. So what does this mean for you and your providers? Well, providers can document encounters in a way, hopefully, that makes sense to them and supports their decision making. Again, the hope is that there's less time clicking in the EHR when you're documenting, the HPI, the review of systems, and the exam, since there's no need to document, a certain number of points or body systems. Providers only have to document what is medically appropriate. This could mean potentially an opportunity to consider or even reconsider Nextgen Mobile, or Nextgen Mobile workflow. The counting of structured data elements is no longer needed for code determination, so it should let providers have greater freedom to use their voice to document and dictate some or all sections of an encounter now. Just food for thought. Again, for Nextgen Enterprise clients, this impact will depend basically on if you utilize these codes and what version you're on. So for 5.9.2020.1 users, when the date has been entered in the 2021 coding guidelines effective date field, which you see in the screenshot, and one of the impacted office visit types is selected for an encounter, the new functionality will be present on your finalized template. If no date is entered in the new functionality, it will not be in effect. Also, either that 95 or 97 coding guidelines radio button must be selected to indicate which guidelines will be used for E&M code calculation for other visit types and encounters, prior to that effective date. So there's a bit of setup, I guess we could call it, just making sure you do these two things in the practice configuration template. I will note the effective date is obviously configurable, so new functionality for that 2021 guidelines will be in place for any encounter on or after that effective date. They did this to allow for testing prior to that January 1st deadline. So here's what the finalized template will look like. You can see finalized templates are now updated to select an office visit E&M based on MDM level or time. That time includes not only time with the patient, but also documentation. There are helpful links to the new MDM guidelines, as well as a new risk table provided for the provider's reference to determine and select that MDM level. Time calculations have now been updated to include the new time thresholds for the office visit codes. And then the last thing I'll point out is the calculate code option, which can still be used, but many providers, we know will select their own E&M code directly. Now, if you're not on 5.9.2020.1 and you don't plan to upgrade before next year, you might be wondering, well, what the heck am I supposed to do? Well, there has been a pop-up created that will launch from the finalized template. As you can see here, it has the same links and option for code selection with updated time thresholds. And this functionality has actually already been released last May in a patch for versions 5.9.3, 5.9.2, 5.9.1, and 5.9. So as promised, at the end of each section, we have these kind of helpful next-gen requirements broken down for you by each topic. So for E&M coding, you have a few options with considerations to keep in mind for each. First is obviously to upgrade to 5.9.2020.1 by January 1st. With that, your coding calculations will be built into the finalized template. 9.9.2.0.1 is already removed from the billing template. And overall, you're most likely going to spend less time educating providers on these changes because each code breaks down the new coding guidelines for you. You do have the option, though, to take a patch. You can either take patch 2, which is available now, or patch 3, which should be available in fall of 2020, and it covers AUC as well, which we'll talk about next. And you need to apply that before January 1st. If you choose this route, just keep in mind more time will need to be spent educating providers on the new guidelines. You know, your providers may need to manually select the code because the older versions will still be calculating based on that 95 or 97 guidelines. And then customizations will need to be performed to remove that 99201. All right, so moving on to AUC, or appropriate use criteria. So the appropriate use criteria program, or AUC, is part of the Protecting Access to Medicare Act, or PAMA, and it actually officially began on January 1st of this year. So as part of this program, ordering providers are required to consult AUC for all Medicare Part B advanced diagnostic imaging services. And they need to do that through a qualified clinical decision support mechanism. So when I say advanced diagnostic imaging, think CTs, MRIs, PET scans, and nuclear medicine. This does not include x-rays, ultrasounds, or fluoroscopy services. So if your practice doesn't order any advanced diagnostic imaging, then lucky you. You do not have to worry about this, and you get, I would say, probably 7 to 8 minutes to check your email, maybe get a quick snack. For the rest of you, you should know Nextgen has partnered with the National Decision Support Company. I'll refer to them as NDSC throughout this as their, QCDSM, their Qualified Clinical Decision Support Mechanism, and has integrated the solution into the EHR at the time of ordering that advanced imaging. So both healthcare providers in physician offices and diagnostic testing facilities are going to be impacted by this regulation. CMS designated 2020 as, the educational and testing period. During this testing period, claim reimbursement is not affected. Starting January 1st, 2021, it will be. So starting next year, AUC consultation details must be added to diagnostic service claims to avoid rejections or payment reductions. This means providers should include an AUC score. That'll be a number 1 to 9, 1 being not appropriate, so a higher score is better. The G code indicating that that CDSM was used. Nextgen users should all have that NDSC, that National Decision Support Company, since that's who they partnered with, and a modifier if the CDSM was consulted or why it was not. And you can see the screenshot for a list of the updated modifiers and their meanings. And then Medicare Part B claims that fail to append all this information will not be paid. So they are not messing around here, they're playing hardball, and I don't expect this to be delayed at all due to COVID. Now, for Nextgen users specifically, when ordering advanced diagnostic imaging, the AUC process is triggered once the following criteria have been completed. So the patient's insurance has been identified, during setup as a payer that was requiring AUC rules. And the diagnosis or assessment for the test has been selected. So the orders module and CPOE solutions support the AUC workflow, and the following templates also trigger the AUC workflow based on selection of advanced imaging test. This means it can be done through the orders module and or KBM now called ACE, templates when ordering. So let's compare the two, depending on what your practice is using, a little bit different. So first, if you're using the orders module, you're going to select your diagnosis, select the advanced imaging test. The AUC check will actually automatically run, and then the end user should be presented with the AUC score wizard, showing your score for that selected test, and then also showing any suggested alternative tests. You would select the test you want to proceed with for the order. Now, for the template ordering, again, the user would select the diagnosis or assessment. You would have the advanced imaging test. You're presented with that AUC score wizard again. Here's where it's different. The user can only choose to pick their original test when that list of alternative comes up. If they want to change to an alternate test, they will need to close and reselect that test. So overall, it's a very similar workflow, just a limitation with templates to not be able to select an alternative test without closing and reselecting. All right, well, let's get an idea, of what this actually looks like for both scenarios. So first is the orders module. You can see upon selection of the imaging study, the AUC process sends the selected test and diagnosis to NDSC via a web service. If this information is enough to provide an AUC score directly, the user will see the score wizard with the AUC details and the alternative exams. If alternative test is selected, it'll update and display as the current order. In most cases, the AUC process requires selection of one or more clinical indications to further specify the need for the exam. So this list is presented to the user as part of the response from NDSC. After another indication is selected, an AUC score and that alternative list is provided. The provider would then decide, which test they would like to move forward with. That AUC score, the unique decision support number, and the corresponding appropriateness modifiers are stored to the database as part of the details of that order. When the order is then, sent externally across that HL7 interface, or, the ordering requisition is printed from EHR, this AUC detail is communicated to the furnishing facility that will be performing and billing for the study. Now, what this looks like in the templates, very similar process. You can see we are on the Diagnostics tab, ordering a CT, where the AUC wizard opens up, where more indications may be required. And then you see the exam score, just like with the orders module version. So again, just to kind of reiterate what's happening behind the scenes when you're performing the workflow and what's required for payment, that consultation data will be reported as that G1004 code, which represents NDSC, that QCDSM that's integrated with Nextgen. The test being ordered for the patient is run through that score wizard for determination of the AUC compliance score. That score is going to correlate directly to the HCPCS modifier. And then facilities performing the diagnostic imaging will need to apply the G code on a separate claim line and the modifier for the service performed to their claim. So below, you can see an example section of the printed requisition showing the AUC required elements for communication to the furnishing facility. This is from, 59.2020.1 version. All of this has that we've walked through. You can, obviously see the AUC score, the modifier and the G code at the top, and then the reference descriptions at the bottom. This particular test was an MRI with a score of 7 out of 9, pretty good high level of appropriateness. Now, I won't pretend to be a Nextgen expert here. We have a whole team of consultants who this is their bread and butter, but I did want to give you a reference slide as a heads up. There is some setup involved for this to work as I described. So first stop will be file maintenance. So in the payer master file, the Medicare financial class should already be configured, but any additional financial classes can be added. So you can see on the right in the modify payer information window, you have that checkbox enabled. Next, in the Nextgen compendium, diagnostic studies need to be flagged as requiring an AUC check and then mapped to the corresponding CPT code. If you aren't using the Nextgen compendium for ordering, you need to map vendor test codes for AUC compliance and again, map that to the corresponding CPT code like you see in this screenshot. And then last stop in file maintenance would be practice preferences. you need to set the threshold for the scoring window. So you can see in this example, it's set at 7. And then outside of file maintenance, you will want to go into the EHR and into the practice configuration template. And you would want to enable the AUC rules for template ordering. You can see that checkbox all the way at the bottom. We were already in here for the E&M brief coding setup as well. Now, just like E&M coding changes, you do have 2 options to accommodate this new requirement. First is obviously upgrade to 5.9.2020.1 by January 1st. Nextgen is encouraging clients to upgrade to the upcoming version to have full support for AUC, including integration with HL7 interfaces, additional specialty workflows, and the first phase of claims automation. However, you can also apply a patch. This will be patch 3, and it's not available yet, but it is planned to be released later this year with all the combined AUC capabilities for clients all the way back to 5.9. Nextgen has said fall of 2020. It is a cumulative patch, so it would include the 2021 E&M coding and AUC requirements. So, if you want to take this one patch instead of taking 2 separate packages, you can wait, and it would include both. Just keep in mind, without upgrading, clients will need to work with their diagnostic facilities on how to best communicate the claims details. This could be accomplished through customizations on documents. So I'm hoping the graphic I showed at the beginning with the timelines on it of upgrades and patches will make even more sense and have more meaning when you all go back and review it once the slides are sent out. And if you are wondering, what specifically the differences will look like by version, similar to how we did with E&M coding, it's just a bit more extensive, as each version of 5.9 provides something different, showing obviously the later the version, the better. I'm not going to walk you through each of these, as I encourage you to find your current version in the row, and then review its own considerations on if you manually map radiology tests, if the outbound HL7 will pass the AUC score and or the G code and modifier, and if it will be on all printed requisitions. All right, well, for our next topic, I'm going to go ahead and turn it over to Carly to take you through some pretty brief, but still important updates you should be aware of. And the first of which is the API update. So Carly, it is all yours.
All right, thank you, Lindsay. So in order to improve the reliability, performance, and scalability of the API platform for future market and regulatory demands, an improved API platform will be launching on August 21st. The June 26th API patch automatically updated or installed Microsoft.NET Core version 3.1.3 in preparation for this launch. So what do you need to do to remain compliant? Well, if you're hosted by Nextgen or you're a reseller, there's actually no action required on your part. But if your organization is self-hosted, you will need to ensure that you complete all of the following steps before August 21st. So you need to verify Microsoft.NET Core 3.1.3 is installed, ensure that all Nextgen API services are running, ensure the Nextgen API access is configured for all practices, and ensure that the requirements in the installation guide are met. Failure to complete these steps by August 21st will result in being disconnected from the API and all of the following solutions. So Nextgen Virtual Visits, Mobile, Patient Access API, and the Nextgen Enterprise Patient Portal users on version 5.9.2020.1. So again, detailed instructions can be found for these checks in the API Platform Requirements Guide for August 2020 update on the Success community. And this is only necessary, once again, if you are self-hosted. If you're hosted by Nextgen or a reseller, there's nothing to worry about for this on your part. Okay, and then we'll briefly touch on the latest NCPDP update as well. So there is a new NCPDP script standard available, V2017-071. And this is basically just a long way of saying that there's a new e-prescribing standard that is replacing NCPDP script standard V10.6. So this is the e-prescribing standard created to facilitate the transfer of prescription data between pharmacies, prescribers, intermediaries, facilities, and payers. This latest version will modernize e-prescribing, improve patient safety and prescription accuracy, and create workflow efficiencies for healthcare providers and pharmacies. So in order to comply with the new NCDP script version, your organization will either need to, 1, upgrade to that spring 2021 release by September 1st of 2021, or you can take patch 4 by September 1st, 2021. This patch will resolve the medication history issue and it will be available early next year. And you can also see Nextgen's current messaging listed on this slide. They will have a success community page created to post updates related to this topic in the near future. All right, so now we're going to move into our telehealth update. So at this point in 2020, I'm sure no one is unfamiliar with the massive waivers to telehealth that have occurred as a result of the public health emergency. The public health emergency was actually set to expire last Friday on July 24th, unless it was renewed by HHS Secretary Azar. If the PHE was not renewed, the Medicare telehealth waivers authorized by the PHE would have expired on that date as well. So when we were initially going to present this webinar to you about 2 weeks ago, we were expecting the PHE to be renewed. You can kind of see that based off of Michael Caputo's tweet that's on the slide. And luckily, Secretary Azar did officially extend the PHE as of July 25th for an additional 90 days. Providers have relied heavily on various flexibilities that are largely tied to the declaration of the PHE. Some of the more notable policies attached to it include the Medicare inpatient 20% add-on payment for COVID patients, increased federal Medicaid matching rates, requirements that insurers cover COVID-19 testing without cost sharing, and of course the waivers of telehealth restrictions. So once the declaration of the PHE expires or is terminated, so will those dependent waivers and flexibilities unless additional congressional or administrative action is taken in the interim. While this current extension is great news for providers, we do want to advise you to continue to remain watchful of how changes implemented to respond to COVID-19 will have to be reverted once the flexibilities terminate. And this slide just provides an overview of the waivers in place for telehealth during the PHE. Again, I'm sure you guys are really all too familiar with it. So rather than reading through each of these, I just want to provide a brief refresher on some of those major changes that have occurred to Medicare Part B telehealth requirements over the last several months. And of course, many private and state insurers have followed suit and implemented these flexibilities as well. So first we have that removal of the originating site and geographic restrictions, which allows patients to be seen from anywhere, including their homes, rather than just that qualifying rural area or in a healthcare facility. Next, in terms of providers, the list of distant site practitioners able to provide telehealth services was expanded, and FQHCs can now provide services as well. While an audio and video communication must still be in real time and interactive to provide telehealth services, audio-only services are also allowed for E&M visits. The platforms to provide telehealth services can now actually be non-HIPAA compliant, such as FaceTime. And since the public health emergency, over 80 new services are now covered by Medicare via telehealth that were not covered before. With all of these flexibilities also came a pretty drastic increase in reimbursement for both video services and audio-only services. This table demonstrates the increased payment levels for different types of video and audio visits that have come about since the PHE for both facility and office visit rates. And we also included the FQHC telehealth payment rates at the bottom there that are $92. Okay, so the big question is now, will we see permanent changes to telehealth payment and flexibilities? All we know for sure is that there's no simple switch to turn this back off. The Trump administration is not planning to simply have a hard stop on telehealth after months of providers and patients successfully utilizing these services. In an on-the-record press call, Kellyanne Conway noted that the president would like to continue telehealth flexibilities long after the public health emergency. During that same call, CMS Administrator Seema Verma was asked if she could confirm which temporary COVID rules are under consideration for being made permanent, specifically regarding telehealth. She responded that the president has made clear that he wants to explore extending telehealth benefits more widely. She noted that even before the coronavirus, efforts had been made to extend telehealth benefits to seniors by increasing the amount of services that qualify for telehealth and providing shorter visits over the phone or through Skype. The administration is continuing to evaluate all the waivers that they've provided to determine whether they should be extended past the coronavirus. Administrator Verma also stated that they're in the process of rulemaking and that some of the provisions that they have extended on a temporary basis will be made permanent. So beyond announcements from the Trump administration, we've already seen some commercial insurers and individual states take action to make some flexibilities more permanent. A couple examples, so BCBS Tennessee was one of the first groups to make their telehealth changes permanent. In Colorado, we saw the governor sign a bill barring insurers from requiring a pre-established relationship to reimburse for telehealth. And in Idaho, the governor issued an executive order asking state agencies to make permanent telehealth waivers. There's also mounting pressure from various industry organizations to make telehealth flexibilities permanent. For example, on June 23rd, 5 industry organizations, including the American College of Physicians and MGMA, united to send a letter to HHS urging them to continue telehealth waivers and to make them more permanent. At a Senate Help Committee hearing on telehealth on June 17th, Chairman Lamar Alexander said that the federal government should, 1, permanently extend policy changes that allowed physicians to be reimbursed for a telehealth appointment wherever the patient is located, including in the patient's home, and 2, permanently extend the policy change that nearly doubled the number of telehealth services that could be reimbursed by Medicare. He said there were 29 other temporary federal policy changes that could also be considered for being made permanent. And as far as new legislation related to telehealth, 2 days ago, Senate Republicans introduced the HEALS Act. This is the latest bill that has been introduced in the continuing rounds of COVID-19 relief negotiations. And if passed, this bill will extend telehealth flexibilities through the end of the year 2021 or through the end of the public health emergency, whichever lasts longer. Negotiations are probably going to be moving at full speed ahead regarding this bill. Congress does go into recess all of August, which is in 3 days. So there are generous unemployment benefits that are going to expire this Friday. So because of this, I know Congress is probably going to be working pretty fast to negotiate another COVID-19 relief bill, and this could very well be included in that in some way. Now, prior to the release of this HEALS Act proposal in the Senate on Monday, we did see a telehealth-focused bill introduced in the House on July 16th, as pressure mounted from nearly every direction to settle on a way to make telehealth flexibilities more permanent. This bill is called the Protecting Access to Post-COVID-19 Telehealth Act, and it aims to ensure that telehealth is able to continue to build on its potential in the years ahead. This bill will make it easier for Medicare beneficiaries to receive care at home, and it will give HHS the authority to waive requirements during future emergencies. So more specifically, this bill will focus on eliminating those geographic and originating site restrictions on the use of telehealth in Medicare and establishing the patient's home as an eligible distance site so that patients can receive telehealth care at home and doctors can still be reimbursed. It'll also prevent a sudden loss of telehealth services for Medicare beneficiaries by authorizing CMS to continue reimbursement for telehealth for 90 days beyond the public health emergency. It will make permanent the disaster waiver authority, enabling HHS to expand telehealth in Medicare during all future emergencies and disasters. And it's going to require a study on the use of telehealth during COVID, including its costs, uptake rates, measurable health outcomes, and racial and geographic disparities. We've already seen many industry groups rally around this proposal, including the American Telemedicine Association, HIMSS, the Advanced Medical Technology Association, and quite a few others. So we're going to continue to watch for any additional updates on this bill. But unless something happens in the next 2 days, we might have to wait at least another month when Congress is back in session to see any progress on it. And to wrap up our webinar today with a MIPS update and some next steps, I will go ahead and pass this back to Lindsay.
Perfect. Well, thank you, Carly. Well, you know what they say, save the best for last. So of course, MIPS updates for this year will finish out our webinar today. So the biggest news to be aware of is in response to 2019 coronavirus public health emergency, CMS announced flexibilities finally for clinicians participating in MIPS in 2020. So clinicians significantly impacted by the public health emergency may submit what's called an extreme and uncontrollable circumstances application to reweight any or all of the MIPS performance categories. So you can submit an application to have your MIPS quality, cost, improvement activities, and or promoting interoperability performance categories reweighted to 0% due to COVID-19. What the verbiage, CMS actually stated, so you have that, is if the COVID-19 pandemic prevents you or your practice from collecting 2020 MIPS performance period data for an extended period of time, or could impact your performance on cost measures, you can submit an extreme and uncontrollable circumstances application through December 31st of this year. So those of you who are planning on requesting relief and submitting this application, good news, you're not required to submit documentation at the time of submission with your application. However, practices should retain documentation of your circumstances supporting your application for your own records in the event that you're selected by CMS for an audit. A lot of people ask me, well, what kind of documentation would you suggest? And it could be anything, quality reports comparing your numbers from last year to this year, maybe your first quarter data quality reports compared to your second quarter data when things, COVID related really kicked up. Especially to see the difference, maybe if you were an ASC and you were shut down. I have even heard people wanting to give a list of furloughed employees with their responsibilities related to MIPS listed with that. CMS doesn't provide any guidance, shocker, and I don't imagine them doing extensive audits on this application, to be honest. However, you do need to have something in your audit binder if you plan to utilize this, just to be safe. So here is the info CMS isn't highlighting. And if you stayed on this long, I'm proud of you and you get kind of the insider info here. So one, you can submit the application now and then still actually submit data for the MIPS performance categories you selected in that application later. What that means is basically data submission overrides the performance category reweighting. However, I do want to note if you were approved for reweighting of the cost performance category, you will never be scored on cost measures because there's no data submission associated with it. So cost is the only one you kind of can't go back on. And then number two, and this is the important one, and what I'm actually telling all my clients to do is you're only required to submit data on at least 2 categories in order to be scored and eligible for a possible positive incentive. So the reweighting options are shown in that table on your screen, but it makes things a lot easier and more predictable if you can exclude from cost and maybe PI and only have to focus on your quality measures and improvement activities. Or maybe, you're the opposite. You've been doing meaningful use for ages now. You've got your PI workflows down and it's only 90 days. So you don't want to have to worry about your quality data for the full year. And, you want to submit your improvement activities in PI. Either way, it gives you more control over your data than any other year. But you do need to submit 2 categories to get scored. You can't only do 1. So the application is available now through December 31st of this year. Now, to submit an application, unlike previous years, if you ever submitted one of these before, maybe you're a small practice or you were affected by a natural disaster of any kind, you just were able to submit it from the QPP website. This year, you have to actually sign into the CMS portal. So I am sure a lot of you will need to track down who at your practice or organization has your CMS login, and or better yet, register one for yourself and get linked to your tax ID before you can do this. I've done this and helped with multiple clients for this, so I'm telling you now, it's a bit of a process. It doesn't always turn out to happen, you know, in one day. So what that means is please don't wait until December 31st to figure this out. Give yourself at least a week or so. Now, really quickly, what does this hardship application actually mean besides, you know, a free year off of MIPS or an easier year to earn an incentive, whichever way you're going to choose to look at it? Well, with the 2020 data submission flexibilities announced by CMS, this will likely result in even lower positive payment adjustments than we've seen in the past. I mean, they're basically giving everyone an out this year. So because of that kind of increased number of clinicians that are going to receive a neutral adjustment, that means fewer clinicians are going to receive a penalty. And those penalties are what fund the incentives. So we finally thought we were going to see some real incentive percentages this year, and then of course COVID. But keep in mind, you know, the threshold to avoid a penalty is 45 points if you submit data, and then the threshold to earn an exceptional performance bonus is 85 points. This means if your provider or your practice group data is scoring over 85 points, you should still submit and collect the possible positive incentive. And that's because that exceptional performance bonus, it's a pot of, you know, 500 million. It's only available for the first 5 years of the program, which means next year is already the last year for it. And then lastly, for all of you who have been keeping up on MIPS, you do know CMS announced the MIPS value pathways last year to essentially overhaul the program again. CMS hasn't issued any guidance about the potential impact COVID-19 may have had on MVPs. We do anticipate more information in the upcoming physician fee schedule proposed rule, which should be released soon. This rule will update MIPS, tell us more about the MVPs, and likely include more COVID-19 related changes. This is the rule that usually always gets finalized that first week in November, right around UGM time. All right, so we have made it to the end. As the picture says, thank God that's over. I made you a quick, maybe not quick, it was quick for me to make, maybe not for you to complete, but to-do list for everything we went over. If you're like me, this is how I survive on a daily basis, so consider it my gift to you, and hopefully you can start checking some things off very soon here. And that brings us to the end. I think we'll go ahead and open it up for questions if you have any. I apologize for kind of the time limitations here. I knew we would kind of take up the full time, but we hope you found the content timely and helpful. We really are here to help in any way we can. So feel free to visit our website and continue to sign up for our webinars. We have some good content coming, but also consider some of the services we offer. Carly and I both help out with macro packages that we have available. We also actually have a few new services we're rolling out. Really exciting stuff such as the Healthcare Advisor Package, grant writing assistance, and even value-based contract assistance. So if you want to learn more about any of these products or services, you know, feel free to reach out on our website or email me directly. And to do that, you need my contact information. So here's mine as well as Carly's. So I will turn it over to Chelsea for you to kind of facilitate any questions you might have.
Okay, thank you, Lindsay, and thank you, Carly. It looks like we only have a couple of questions, so either these people are completely fried or you presented so much information, you've answered absolutely all their questions. I'm not sure which one it is, Lindsay.
I'm almost out of breath, so I'm going to go with I answered all their questions already.
Okay, first question. On AUC, can we begin testing now without the patch being available?
So in order to actually, you know, begin testing that and doing that, you need to have the patch available. So, you know, they originally started, you know, late summer. So I expect the patch would be available early fall because you're not going to see any of that functionality until the patch is actually applied or installed.
Okay, currently last question, but if you have questions, feel free to type them in. We'll hang on a few more minutes to answer them. Will we receive a recording of this webinar? And the answer is absolutely yes. I'll be sending out a link to the recording and slides within the next few days here. If you don't get those, sometimes they get caught in people's spam folders. You can always head directly to the events and education page on our website, and you can always download the slides there directly as well. Oh, we got another question. Regarding E&M changes in 2021, is this only applicable to office visits or will it apply to ER visits also?
So these E&M changes are only applicable to the office visits that use that code 99202 to 99215. So, I've heard from some people, this might not impact you, which is great news. If you got to dodge E&M coding changes and AUC, that's very exciting. But the specifics regarding that really, and I have that in the slides too when we send them out, are just that specific code range. So if you've used any of those codes, it will impact you, and they do have a lot of information out there, on the different coding websites and resources that I'm sure, your coders or billing departments have seen and are aware of as well.
Okay, perfect. Well, it looks like that's all of the questions. So, we'll send out these slides. If you have questions after you have a chance to review them, if something pops into your head later, you see both Lindsay's and Carly's information up on the screen. You can also always reply back to the emails that I'll be sending, either the invitation that you already received to be here today, or you can reply to the recording email as well. Basically, any way that you can get a hold of us, we're happy to help. We know this is a whole lot of information, and Lindsay and Carly went through that really quick. So don't be ashamed if you have questions. It's a lot. We're happy to help.
Yeah, feel free to reach out and shoot me an email. I have no problem with that. And let me know if you're interested in learning anything more about the different kind of options that we offer to help you guys stay aware and on top of all this stuff as well.
Perfect. Well, thank you, everybody. Thank you for joining us. Lindsay, Carly, thank you for putting this together. I'm glad that you're feeling better, and hope that everybody has a great week. Stay healthy, and thanks for joining us.
Great. Thank you, everyone.